Before I start my talk, I will just give a little background as to how I got involved in cryoablation. I knew about cryogenics, where they freeze people's heads and bodies so that when they are born again someday, they will be in good shape. But 7, 8 years ago, when St. Joseph Hospital established their cancer center, I was approached by one of the directors there and said, you know, Gero, we have surgical representation, we have radiation therapy, but in order to be a true cancer center, we also have to provide cryoablation. Are you interested in doing it? And it was the last thing I needed because, you know, I was so busy already, but I can never say no to new ideas. So I left everything. I went to get training at another institution. I came back. I had to fight bureaucracy in hospitals because this was a new thing and they were scared of it. Finally, we got started. 7 years later and about 150 cases down the line, I am still excited by this technique. Unfortunately, as I will mention, it's still understated and seldom used, but we are seeing some increased understanding, especially the treatment of the elderly prostate cancer patient who needs local control to avoid future complications related to untreated local aggressive cancer. So when you have prostate cancer, the treatment options for the localized disease is active surveillance, like Dr. Greenberger aptly covered. It's some kind of prostatectomy, robotic, and open. A few years ago, the open was first, and the robotic was next. When I revised my slides, I had to put robotic first, because as of today, about 75 to 80% of all radical prostatectomies in this country are being done by robotic. And this is, I think, the standard of care. Bill said maybe, but no, it's not. I think it is the standard of care. Radiation therapy, of course, remains an important tool in treatment of prostate cancer, whether it's in the form of a external beam radiation, like IMRT and others, brachytherapy, or a combination of both. And then the last kid on the block to hit the treatment group is cryoablation. And other words for that is cryosurgery, cryotherapy, or cryo for short. And then the treatment options for non-curative options for advanced disease basically are active surveillance if the patient doesn't want anything done, and then hospice. Hormone ablation therapy is what we have, or some new chemotherapeutic agents that are still, I think, are experimental, and we don't have any definite controlled studies to show their efficacy. So what is cryoablation? Most importantly, it's a minimally invasive percutaneous procedure. And it destroys cancer cells by exposing targeted tissues to lethal cold temperatures. And in the case of urology, the prostate and the kidney lend themselves very well to this treatment. It's an outpatient procedure, and patients return to normal activity usually within 2 weeks. It's a Medicare-approved and covered procedure since 1999, and most health plans cover it, including the PPO health plans. However, it is still a seldom used treatment because a lot of urologists don't know much about it, or since they are not trained, or they don't even discuss it. And I see that, unfortunately, pretty often. So it's a seldom used treatment modality for prostate cancer in the community compared to surgery and radiation. How did cryoablation evolve? It was first tried in the early 1960s using a transurethral approach monitored with digital rectal examination. They did not have ultrasounds, bipolar, whatever. The surgeon would put his finger in there and then do something. The technique was abandoned until the early 1990s because of significant complications, such as the absence of imaging, non-insulated probes with gas leaks. At that time, they used nitrogen, which leaked very easily, rectal and urethral injuries leading to horrible fistulas. However, the research continued in academic centers, and especially in Columbia University Hospital in New York, to improve the technique and make it more practical. So cryo was reintroduced to the clinical field in the early 1990s because of significant technical and procedural advances. Improved biplane sonography, vacuum-insulated cryoprobes, temp probes or temperature probes, intraoperative treatment planning, urethral warmer, etc. The number of prostate cancer cases treated by cryo is increasing annually. 5,600 cases in 2004, and estimated 12,000 cases in 2011. It's still only 6% of prostate cancer cases are treated by cryo today. So what are the indications for this technique? A targeted cryoablation of the prostate candidate is a prostate cancer patient who has primary stage T1 to T3 prostate cancer. The T3 is important to notice because surgeons usually will shy away from doing T3 cases, and radiation is well proven not to be very effective in locally bulky advanced disease. He does not want surgery or radiation after being given those options. He is a high risk for surgery or radiation, advanced age, comorbid diseases, high grade, locally advanced, etc. He is quite concerned about incontinence, but he is not concerned about post-operative erectile dysfunction or already has impotence. My average patient age is about 70, 75, and a lot of them already, they go, oh, no, that's okay. You know, and then they look at their wife, and the wife says yes, you know. Plus, we tell them that it's treatable condition, so that really makes it less bad. So, and then the candidate wants a procedure that can be repeated, something that cannot be said about radiation or surgery. They want a minimally invasive procedure with a quick recovery, or they need a salvage procedure after failed radiation therapy, and we see quite a few of those. How does cryoablation work? What is so magic about it? So when you're freezing the tissue, anti-neoplastic effects result from direct cytolysis via extracellular and intracellular ice crystal formation, intracellular dehydration with pH changes, ischemic necrosis via vascular injury, activation of anti-tumor immune responses, induction of apoptosis, which means cell death, endothelial damage with platelet aggregation and microthrombosis. Now, when you are doing the thawing phase, because when you freeze it, you have to thaw it, additional effects result on the tissues by osmotic cellular swelling and vascular hyperpermeability, and a minimum freezing temperature of -40 degrees, which is also -40 Fahrenheit, for 3 minutes is necessary for efficient tumor eradication. In clinical practice, we do 2 of those cycles. And this is a cartoon showing pretty much what happens. Do we have a... Anyway, the cell is happy in the beginning because it's in the warm environment, and then you hit them with the cold. Ice crystals start forming in the cytoplasm, and a variety of effects that I mentioned, osmosis and all that, lead to the breakup of the cell and also to the destruction of the genetic material in the cells. And as a result,